So what I want to do today is to introduce a topic which will probably need 3 sessions to finish properly. It's called skeletal dysplasias. That's the name of the topic. We will need 3 sessions because it's a very big topic. 3.5 to 4 sessions. We'll see how it goes, but hopefully we'll be able to finish it in 3 sessions. It's a little bit complex, but I think it can be understood the more you listen to this talk later on, and also when you scan, if you begin to try and appreciate the things that we'll be discussing here today, the better. Like we have said before, that if you are working in a fetal medicine unit, you have to be knowledgeable about the fetal defects to an extent, so that you don't miss the obvious defects. Because if you miss the obvious defects, the question is who will pick them? Who will improve the prenatal diagnosis of fetal conditions? This is why we are doing this series, so that everyone who is in the fetal medicine unit becomes more knowledgeable and is also becomes more aware as you scan. I think all of you, without doubt, you now know that babies have defects. It's no longer a case of probably it's you all know that they have defects. So skeletal dysplasia the prevalence is quoted as 1 in 4,000. Generally, that is if we group all of them. However, some are more rare than others. The sad part of the skeletal defects is that 25% are stillborn and 30% die in the neonatal period. So generally, they do not have a good outcome, most of them. When you say 1 in 4,000, in fetal medicine terms, that is a lot. We say it's a lot because, as an example, Zimbabwe delivers about 400,000 women a year. So if I say 1 in 4,000, that means you have a potential of having 400 cases, right? So these are how common it is. Of these skeletal defects. So do not think this is an uncommon occurrence. It is very common in fetal medicine terms. Then the approach to diagnosis, there is a wide range of rare skeletal dysplasias, each with a specific recurrent risk, dysmorphic expression or dysmorphic features, and implications for neonatal survival and the quality of life. What does this statement mean to us? It means we should have the knowledge of the different or the morphological pattern of these different skeletal dysplasias, so that we are able prenatally to diagnose the most likely skeletal defect, so that we can counsel the couple appropriately and offer them the right kind of pregnancy care plan. The incidental discovery of a skeletal dysplasia on routine ultrasound screening in pregnancy not known to be at risk of specific syndrome necessitates systemic examination of the limbs, head, thorax, spine to arrive at the correct diagnosis. You will see that most skeletal defects affect the above mentioned structures. Hence, it is important to know what we may call syndromic pattern, to say if the pattern is like this, which skeletal dysplasia is more likely. Then the assessment of the long bones. the shortening of the long bond is one of the, let me say, the window to diagnosing of skeletal dysplasias. So the shortening of extremities can affect the entire limb when the whole limb is absent, is affected. For example, both the radius, ulna, humerus are short. The condition is known as micromelia. Micromelia. If the humerus or femur are affected only, and the tibias, fibula, radius, and ulna are of normal size, the condition is known as rhizomelia. Then if we have the radius, ulna, tibia, or fibula affected, yet the femur and the humerus are normal, the condition is known as mesomelia. So remember these terms, it's very important, and also the spelling. Well, sometimes you see the reports that we dictate, the conclusion we dictate, the spelling, sometimes they leave a lot to desire. So remember the spellings, very important. If the hands and the feet appear short, then the condition is called acromelia. The femur is abnormally short, even in mesomelic dwarfism, and therefore in routine fetal abnormality screening, the femur is measured and compared subjectively to all long bones. Severe limb reduction, as in thanatophoric dwarfism, and achondrogenesis can be detected from 16 weeks of gestation. Whereas in achondroplasia, limb shortening becomes evident from 22 weeks. So remember this. This is very important and key when you are following up women who have had the history of skeletal dysplasia. So you cannot reassure a woman that, look, your baby does not have skeletal dysplasia because they have come for a 20-week anomaly scan and the limbs that you have measured appeared normal. Remember, we in our protocol, we normally ask women with skeletal dysplasia to come back around 25 weeks if they pass the 20-week anomaly scan. So around 25 weeks, they have to come back again, and we check again the extremities. So remember this, because it's very important. Otherwise, you may see somebody who said short skeletal dysplasia baby. They come at 20-week anomaly scan. You do the routine anomaly scan, and everything looks normal. You cannot reassure the woman and say, "Look, you're okay," because it will be too early. Because the shortening happens as you enter into the third trimester for most of these cases. Then, as part of screening for skeletal dysplasia, we also assess for the abnormal shape. The abnormal shape, both of the head and also the extremities. What you normally see is the bowing of the legs of the long bones, which is shown in which is normally evident in the femur and the tibia and the fibula in most of the cases. There are two main skeletal dysplasia that normally cause this. We have campomelic dysplasia and the thanatophoric dwarfism or thanatophoric dysplasia. Then in others, there are fractures and the callus formation, which may also be detected in conditions such as osteogenesis imperfecta and achondrogenesis and hypophosphatasia. Each of these conditions we're going to address them individually. So we'll have more detail on all these conditions that we are mentioning, because some of you may be wondering, what is osteogenesis imperfecta? What is thanatophoric dysplasia? We will cover all this. Like I told you, it's a very longish topic which will take us 3 sessions to go through. Then we also assess for echogenicity, to see how echogenic are the bones as part of skeletal dysplasia or skeletal survey workup. The hypomineralization is normally seen in certain disorders such as hypophosphatasia, osteogenesis imperfecta, and achondrogenesis. Please take note, there's a difference between achondrogenesis and achondroplasia. The difference is huge. So don't mix the two, because it could lead to grave consequences in terms of the pregnancy plan. Then visual absence of ossification of the spine in achondrogenesis may lead to erroneous diagnosis of complete spinal agenesis. Poor mineralization of the skull in hypophosphatasia may also result in the diagnosis of hydrocephalus. Very important, these 2 points there, because I think we've seen some cases of skeletal dysplasias who have been labeled as hydrocephalus before. There are not many though. Then we have the situation of absence of extremities. When there's complete absence of extremities, the condition is called amelia. Probably you may see these kind of terms when you do the drop downs on limbs in the pyramid anatomy appearance. Amelia means there are no limbs at all. Then we can also have acaria. Acaria means there is absence of the hand. We have everything, but the hand is missing. These defects do occur for real. Do not think they are fiction, right? They do occur for real. We have seen probably most of them already. Focomelia, these are seal limb. That means there's fusion, probably like a mermaid, right? Yeah, seal limb. We've shown you focomelia when we were doing the CNS, but we'll probably show you again as you do the detail of each of these conditions. Or there's aplasia, hypoplasia of the radius or ulna. These are often inherited as part of a genetic syndrome, hot oram syndrome. Or this could also occur in a condition where there's thrombocytopenia with absent radii syndrome, which is another cause of focal limb loss. Then we can also have limb loss in conditions such as amniotic bend syndrome. Yeah. Then evaluation of the hands and the feet. We could have polydactyly. Polydactyly means the presence of more than 5 digits. It is classified as postaxial if the extra digits are on the ulnar or fibular side. Ulnar side is the side where there's a small finger. So if you have it on the side of the small finger, then you know that that's postaxial polydactyly. If it is present on the side of the thumb or radius or tibia, on the side of the thumb, if it is present on the side of the thumb, then it's called preaxial polydactyly. So we are saying if the extra digit is on the right, on the side of the thumb, it's called preaxial polydactyly. Synedactyly, this is where there is fusion of the digits, where there is soft tissue or bone fusion of adjacent digits. It's called synedactyly. We should know these terms, very important to know these terms. Then we have clinodactyly, which is a deviation of a finger, normally deviates inwards. This normally happens to the little finger, and you normally see this in babies' downs. So if it deviates inside, it's called tenoidactyly, normally due to hypoplasia of the middle phalanx. So it deviates inside. It's called clinodactyly. It's one of the markers of Down syndrome we have to look for in a very high risk cases where we have to look for soft markers, those who have not undergone NIPT. Then we have disproportion between hands and feet and other parts of the extremities, which may also be a sign of skeletal dysplasia. Then, in addition, we check for the movements. We say, is the baby really moving? As part of skeletal survey, babies have to move. And if the baby is not moving during your time of scanning, try to stimulate the baby to move. Babies can be stimulated even by simple tapping of the mother's tummy with your probe in a gentle way without harming the mother. And you should always communicate to the mother in advance so that she knows what you are doing, so that she doesn't become, it doesn't look awkward to her. So always warn the mother that, look, I just want to stimulate your baby and say, get to see some movements, because it's part of normal, it's part of routine assessment of the baby's well-being. You should see some movement during scanning. If you don't see them, then it's not a good thing not to see the movements. What else can you do to encourage the movements? If it is a case where you are borderline and you're not sure and you really want to see the movements, you can encourage the mother to just go and take a cold drink or just a glass of cold water. Normally, that should bring about the movements in babies who are normal, who have the movements in them. So that's another maneuver you can also do. Or you can ask the mother to just take some star jumps. Normally, that tends to shake up the baby and wake up those sleeping babies. So remember this, that you can do certain maneuvers to encourage the baby to move. So the absence of movements will bring us to two conditions. We have arthrogryposis and multiple pterygium syndrome. We also have another condition called fetal akinesia deformation sequencing, where with this condition, there may be limited flexion or extension of the limbs. With the pterygium syndrome, with arthrogryposis, it's more like contractures are forming around the joints, and with the multiple pterygium, it's more like there are webs of tissue around the joint area, so that tends to limit the movement of the joints. These conditions will be covered separately, like I said, as we go through we are still on the evaluation skeletal survey as part of the skeletal dysplasia topic. Then evaluation of the thorax. Several skeletal dysplasias are associated with small thorax, which normally leads to pulmonary hypoplasia and neonatal death. This is why thoracic circumference is very important as part of skeletal survey, because it determines, in most cases, whether we are going to label this skeletal dysplasia lethal or non-lethal. The diagnosis of a small thorax is normally made by calculating what we call abdominal circumference ratio, or the thoracic to head ratio, to head circumference ratio. We will cover this when you look at the condition separately, including the cutoff to say when would you worry about the thoracic circumference, thoracic to abdominal circumference ratio, or thoracic to head circumference ratio. This will be covered. The thoracic circumference is measured at the level of the four-chamber view of the heart. So remember this. I think those who work with us in the fetal defects have seen us doing this. It's not complicated. So to just sort of give you an overview of some of the conditions, we will cover them in detail separately. But to just give you an overview of the condition, this table, which is sort of comparing different types of them. Starting with the thanatophoric dysplasia, you should always know that they are type 1 and 2. Of course, the distinction of the type probably is more on the academic side, but on the pregnancy care side, the result is the same. Unfortunately, this condition is lethal. That means it's not compatible with life. In terms of how it comes about, it's sporadic. That means there is no inheritance pattern. We cannot tell the woman that, look, you inherited the genes from so and so, that's why your baby is like this. It just comes, just de novo. It is as common as 1 in 10,000. Probably it's one of the most commonest defects, which explains why, even in our database, is the most commonest defect. Skeletal dysplasia. Then what are the features? The limbs are very short, the thorax is narrow, the trunk is normal. That means it's a normal trunk length. The head is large with a prominent forehead. This is in type 1, in both of them, sorry. These are features which are common to both. Then in type 1, the femurs, they are curved with a telephone receiver, kind of, those old telephone receivers. Because there is a new generation who don't know those telephone receivers, right? The old ones, which were very much curved. Then then the femur is straight in the type 2, and there is what we call a clover leaf shaped head in the type 2. The clover leaf, maybe we'll demonstrate on the condition, say what does a clover leaf shaped head looks like. Yeah, this will be demonstrable. I think we have a number of cases from our own library and database. So we'll show you this clover leaf shaped head. Then osteogenesis imperfecta is as common as 1 in 15,000. It's autosomal dominant. That means the genes are passed on from the parent to the offspring. If one of them has it, then there's a high chance of passing it on to the offspring. Unfortunately, there are what, 4 types? There are 2 main types, which we pick prenatally. The type 1 and type 2, but they can go up to type 4. Some of them we cannot pick them prenatally. We will discuss further as we do it separately. No, for achondrogenesis, there's just 2 types. I was thinking of osteogenesis imperfecta. Yeah, that's the one. Osteogenesis imperfecta. Yeah, so I was saying there are 3 types, but the ones we pick are prenatal are type 2 and type 3. There are 4 types actually. Yeah, that's correct. 4 types. We'll discuss the other types as we do osteogenesis imperfecta. So it's as common as 1 in 15,000. Fairly common again in fetal medicine terms. It's lethal, unfortunately. The hallmark feature of this condition is that they are fragile bones. Like I said, there are many types, mainly four main types recognized, but others say there are more than that. And type 2 and type 3 is what concerns us, fetal medicine people. Well, this is what we can pick prenatal. This is why we just have these 2 here. In type 1, the limbs are short with fractures. The thorax is small with multiple fractures of the ribs, and the head, there is hypomineralization of the skull, and it is quite depressible. And you tend to visualize brain anatomy more than usual, even late 3rd trimester, because of the hypomineralization of the skull. Then for the type 2, there are multiple fractures. Type 3, so for the type 3 is type 2 and type 3. There are multiple fractures, usually present at birth, and result in scoliosis and very short stature. The outcome is variable for the type 3. Then achondroplasia. As common as 1 in 25,000, fairly common. And it is inherited as an autosomal dominant. The achondroplasia is probably the most commonest skeletal dysplasia that you see, because most of these are the short patients, people who are extremely short. I think we've all seen them coming to our antenatal clinics and also to the fetal medicine, both parental and necessarily. we have followed up, and I think at Sali we are still following up. I think both hospitals, we are still following up women with this condition. Some have recently delivered. This extremely short women. They're as common as 1 in 25,000. And normally it's a condition with a good prognosis. And they tend to have normal intelligence and fairly normal life expectancy. The limbs are short, but you only pick it up after 22 weeks. The head is large with a prominent forehead, and there's lumbar lordosis on the spine. Lumbar lordosis means it's curving inside. That's the lordosis, not outside like the scoliosis. Scoliosis, right? Yeah. Yeah, it's lumbar lordosis. Then in terms of the achondrogenesis, it is as common as 1 in 4,000. And unfortunately, it is lethal. There are 2 types of achondrogenesis. The common features of both of them is that there is severe limb shortening. We will demonstrate what we mean by severe limb shortening, because sometimes some people may just see this borderline shortening and they may rush to say there is achondrogenesis or achondroplasia, but we'll demonstrate when we do the conditions and by our own examples of these cases that we have managed, so that you can see on the nomograms how short the bones are. For this case, these are not borderline short bones like we see in Down syndrome babies or FGR babies. No, these are extremely short bones. The thorax is narrow, the trunk is short, the head is large with a prominent forehead. It looks more or less similar to achondroplasia, but the chest is very narrow here. And the limbs are extremely, extremely short. This is what makes this condition lethal, especially the very narrow thorax, because there will be underlying hypoplasia, pulmonary hypoplasia. So for the type 1, which is autosomal recessive, that means both parents have to have the genes to be able to pass it on to their offspring. If one person has it, it doesn't pass on to the offspring because it's autosomal recessive. So the parents have to be carrier. They cannot be having achondrogenesis because it is lethal. So these are carrier parents who don't know that they are carrying the gene. Some may be knowing, and they have a 25% chance of passing it on to their offspring. Like we said, the autosomal recessive conditions, that there is a 25% chance that at each pregnancy, they can have a baby with achondrogenesis, type 1. So in type 1, there is, in addition to the above, hypomineralization of the skull, the spine, and we have rib fractures. So it has to be distinguished from the osteogenesis imperfecta as well. Then the type 2, which is sporadic, there is no hypomineralization of the skull, but there is a hypomineralization of the spine, and there are no rib fractures. Then we have asphyxiating thoracic dystrophy, which occurs in about 1 in 70,000. It is autosomal recessive, and it is variable in terms of survival. The limbs are short, but start to appear short after 22 weeks. The thorax is narrow and short. So fairly uncommon, even in fetal medicine terms, 1 in 70,000. Again, the risk of passing it on to the offspring, 1 in 4, 25%, because it's an autosomal recessive condition. Ellis-Van Creveld syndrome occurs in about 1 in 100,000. Again, uncommon. It's an autosomal recessive condition with a variable survival outcome. And the limbs are acromelic and mesomelic. There is acromelic and mesomelic shortening, and post-axial polydactyly. Then the thorax is small, then we could have had defects in about 50% of the cases. Then we have hypophosphatasia. Hypophosphatasia, again, is not a common condition. It's occurs about 1 in 100,000. I think we have one case in our database of this condition. It is autosomal recessive, again, 1 in 4 chance, and it is lethal. The lips are very short, the thorax small, and there is hypomineralization of all the bones. Then carbomelic dysplasia occurs in about 1 in 200,000. It's an autosomal recessive again, and it is lethal. There's short bowed leg bones, narrow hypoplastic scapula. The thorax is narrow and the scapula is hypoplastic. You don't get to see the baby scapula. And we have a large head with a small face. So that's carbomelic dysplasia. Next, we have Jacob-Levin syndrome, which occurs in about 1 in 200,000. It is autosomal recessive. It is variable in terms of the survival. The limbs are of normal length. The thorax is short and narrow, and the trunk is short, and there are fused vertebral bodies and ribs. That's Jacob-Levin syndrome. Then we have dystrophic dysplasia, which occurs in about 1 in 500,000. It is an autosomal recessive. The survival is normal. The limbs are very short and bowed. There's flexion contractures and talipes. There's scoliosis and hitchhiker thumb. So this is a summary of the common conditions skeletal dysplasia that we may likely bump onto as we do the scans. I think I will end here because this is more like an introduction to the skeletal dysplasia. I think I'll be going to the conditions, specific conditions next week. Next week, probably it will be a marathon because we have introduced most of the conditions and we have mentioned their features. So we won't, we'll cover a lot of ground next week so that we can finish this session in 3 working sessions. I think I'll leave the room for questions if you guys do have any questions to ask. So if there are no questions, yeah, otherwise, this is it for today. Enjoy the rest of your day and have an enjoyable weekend. Bye-bye.